Welcome to Childhood Glaucoma, What You Need to Know. My name is Michelle Delizalde, and I am the Assistant Director of Patient and Research Programs at Glaucoma Research Foundation. I'd like to take a moment to thank Aerie Pharmaceuticals for their sponsorship of our webinar series and their continued support of glaucoma patients everywhere. Today, we have Dr. Elena Grajewski joining us. She is professor and chair in ophthalmology at Boscombe Palmer Eye Institute. She is the founder and director of the Samuel and Ethel Balkan International Pediatric Glaucoma Center at Boscombe Palmer. And she is president of the Childhood Glaucoma Research Network, CGRN, which is a network dedicated to physicians and scientists who care for children with glaucoma worldwide. Dr. Grajewski received her medical degree from Chicago Medical School and completed her ophthalmology training at Wills Eye Hospital, which was followed by a glaucoma fellowship at Boscombe Palmer. Dr. Grajewski is an ophthalmologist dedicated to providing integrated care for the treatment of childhood glaucoma, as well as doing research to help save the vision of many children throughout the world. After her presentation, we're going to have a couple more guests join us for the Q&A. We're going to have Hannah Eckstein, a congenital glaucoma patient, and Jeff and Katie Brown, parents to Bennett, who also has congenital glaucoma. They will be sharing their experiences after being diagnosed and how they navigated life afterwards. It is my pleasure and honor to welcome Dr. Grajewski.
Hello, and I want to welcome everybody who has an interest in listening to the story of childhood glaucoma and a little bit about what it takes to diagnose glaucoma in children and infants, and also what it means to treat children or even to be the patient themselves. I'm actually very fortunate to be doing something I love doing. So I am trained in adult glaucoma. And the interesting thing is, while I take care of people of all ages, what I really became known for and what I do now 100% of the time is treat only children with glaucoma. And I was fortunate enough to be able to create a center for children that have glaucoma and to create an integrated care model at this center at Boscombe Palmer Eye Institute, which, by the way, is not really an ice cream parlor. For those of you who aren't familiar with Boscombe Palmer, Boscombe Palmer is the Department of Ophthalmology at the University of Miami in Miami, Florida. Boscombe Palmer has been ranked the #1 eye hospital in the United States for about the last 17 years, is based on U.S. News and World Report. So how common is it? How can it be my entire practice taking care of only infants and children with glaucoma? Well, I think the real frequency of this disorder has changed over the years. Part of it is, like so many things, we've become better at diagnosing glaucoma earlier. And for that reason, our numbers have changed. It is still quite uncommon for a baby to be born with glaucoma and have it be recognized at the time of birth, about 1 in 25,000. But if you take children of all ages from birth to 18 years of age, because there are glaucomas associated with other conditions, it's about 1 in 5,000. And actually, most recently, the U.S. Census on pediatric glaucoma, it's more like 1 in 2,000. If you're in another country, Romania, for example, is probably more like 1 in 1,500. So 1 in 1,000, 1 in 1,500. It is pretty frequent. In fact, oddly enough, Romania has the leading number of pediatric glaucomas at birth in the world. Saudi Arabia is a close second. Is it always at birth? No, hardly. Most of the ones that we see are associated with syndromes. This is myself and a child that has a syndrome. You can see the increased pigmentation on her face, on one half of her face, and that side is the side that has glaucoma. So childhood glaucomas, even juvenile open-angle glaucoma, these glaucomas sometimes are not obvious after the age of 3 years of age. Before the age of 3, we have some other things we can look for that will help a physician, but usually the parent is the first one to notice there could be something wrong. So what do we look for? Well, again, I really think we need to listen to the caregiver. Whoever's holding that baby, giving the bottle, feeding the child, those are the people who really notice, there's something just not right. It is not always as dramatic as you see in these photographs here. One thing that is a very common early sign for parents is that one eye looks bigger or different than the other. Sometimes they'll look cloudy. Sometimes it's tearing and not wanting to be in the light. But clouding is a fairly advanced infantile glaucoma sign. And that represents edema in the cornea, the clear part that covers the front of the eye. So you might ask, why is it different in kids? I mean, almost all of us have heard about glaucoma in adults and older adults. And I think that's always the big surprise. What? Kids get glaucoma? Yeah, they do. But the big what? Why is it different? How can I tell? Is because of that very, very unique age that the child is at the time of the diagnosis, at the time that the pressure in the eye is high. Now, I've avoided using the word pressure in the eye as part of the diagnosis of glaucoma because a lot of times we don't know the pressure at the time that these signs and symptoms are manifest. In fact, it is unlikely that the parents even think of that, but it is the fact that the pressure in the eye is higher than what would be considered normal that is producing the sign that a parent might see, such as a cloudy or a hazy looking surface of the eye. So if you make the diagnosis, is it the same as adult glaucoma, where all of a sudden we start using drops and lasers and that? The answer is no. Pediatric or infantile glaucoma, the kind babies are born with, we may put a child on drops, and I would say I do too, initially, but it is in fact a surgical urgent case. And in fact, during COVID, when all elective cases were being held, we were the busiest at Bascom Palmer Eye Institute, partly because other hospitals in the region, we are the only hospital in Florida that takes care of children with glaucoma, but other hospitals that are known, such as Duke or Emory, which have excellent pediatric glaucoma specialists, and Vanderbilt as well, were closed to operating on children with pediatric glaucoma. And so most of those cases came further south to Miami, where those were done, even if the child was COVID positive, because it is not elective. It is something that needs to be done. And in children that have primary congenital glaucoma, that means the only thing they have is glaucoma and no other abnormalities of the eye. They have a very good chance, if treated promptly and appropriately, with having normal or near normal vision the rest of their life. And if they're not treated promptly, then there can be irreversible vision loss. So this is something that we do during the in order to make the diagnosis is one of the first things, as I mentioned, is going to the operating room. These photographs that you see it's an actual baby. This child and the parents have given permission for these pictures. And this baby's a lot bigger now, but at this age, she was 8 weeks, I think. And this is a very typical first part of an exam under anesthesia. You know, I've been doing this a long time, a really long time. And in the earlier days, I used to have parents come in on the initial portion of the exam. It's not as permitted as much anymore. It is extremely important that this is a team effort, and there's so many people on the team that it can get pretty crowded at this time. But this is a part of the exam where honestly, it could be done in the office, and parts of this are done in the office now with a new device that we've been using actually for quite some time, which is called Rebound Tonometry or eye care. This is a measuring of the intraocular pressure using a device that we call TonoPen. And the thing about measuring the pressure is it's only one part of the whole picture. The pressure is an important part, but it certainly isn't the only part. One of the other things that happen once again is when the pressure is high in a baby's eye during this critical time period from birth to 3 years of age, the eye grows larger. And when it grows larger, that really does mean that the pressure is almost like expanding the eye in such a way that it becomes pathologically, meaning it would not normally have ever been that size, enlarged, which affects every part of the eye. The cornea, the front part, which is normally clear, I mentioned it can be cloudy. It actually can crack and has fluid that can go in between the layers. The lens itself can become a little loose from the stretching. The retina is on stretch. The optic nerve, which is the thing we often talk about with glaucoma, especially in adults, before the age of 3, that is somewhat spared until after the age of 3. So there is reversible cupping or damage to the optic nerve if you can lower the pressure quickly enough. So once again, this is a very urgent condition. This is measuring the cornea. I mentioned that the eye can stretch, and the cornea, and you can, I don't know if you can tell, but I can tell from here that this cornea is cloudy. Normally the cornea, the clear part that's like, again, like the windshield on a car covering the front of the eye, is cloudy here. But it's cloudy because there's fluid in it. And there's fluid in it because it grew so fast that it creates little cracks, it's called, in the cornea where fluid can get inside. All of this is reversible. All of this can be reversible. You can have some scars, but most of the time, once you treat this baby and lower the pressure, then the cornea, even though the crack under a microscope, I can see it, it won't be visible to anybody, and certainly not to the vision of the child. So at that time, we need, after we get all of the measurements we want and everything in place, then it becomes time to make a decision about what are we going to do to treat this child with glaucoma. I mean, I think the most common questions when I tell people children can have or be born with glaucoma, the first question is, you know, how do you even know? Well, now everybody on this webinar knows the answer to that. Big eyes, teary eyes, cloudy eyes are all signs and symptoms. But then how do you treat it? Well, you try to open the natural drain. In this country, that is the first thing that we do. I say in this country because I was fortunate enough to be the editor on an international publication where we have experts from all around the world. In fact, that organization that is the Childhood Glaucoma Research Network, we're in 48 countries. We looked at how is it taken care of in different places. But this tends to be the most common way to treat it initially. And that is, let's give the natural drain that's in the eye a chance to work. And this comes from not new theory, but from a theory from, the 1940s, where there was thought to be a membrane covering the drain in the eye. And that removing this membrane would allow fluid to reach the drain. The analogy of a sink is often used. So it would be as if cellophane was on top of the drain where fluid would go out. So this is removed. And if the drain is there, then there is a good chance that it will begin to work. What if it doesn't work? Well, if it doesn't work, and there are some situations where we know that there's a high likelihood, the drain isn't even present, then we place an artificial drain, which is called a glaucoma shunt, which moves the fluid from the front of the eye to the back of the eye, where it's picked up by the circulation and goes back into the system. What do we do then? Well, to be very, very clear, at this point, everyone does things a little bit differently. So it does depend a lot on the diagnosis, whether or not the child has a syndrome, Axenfeld-Rieger's, aniridia, any one of the others that are associated with childhood glaucomas, juvenile open-angle glaucoma, or whether it's primary congenital glaucoma. And primary congenital glaucoma, once again, is one where they're born with it, but without any other syndrome, meaning no other systemic manifestation of a problem, and without any other manifestation of a problem in the eye other than glaucoma. So it really has turned out that it really depends on what we want to do as far as carrying this out to reach the point where the pressure is such that it doesn't cause the eye to continue to grow. So looking at different areas in the world, it really did depend on how specialized these regions were. So what you could do is very dependent on what you have and the skills of the physicians there. So that's one of the reasons we decided it was in our hands, that we needed to all get together and begin to collaborate and work to find out what is the best way, what are the first things to do, when should we just do medication alone, when do we try medicine, when do we move on to the artificial drain, and to find out what predicted surgery, success or failure or complications. So the knowledge that we had through the Childhood Glaucoma Research Network is really what we leave to everyone who follows in our footsteps, so to speak. You know, the guidelines that have been created have been helpful. They're only guidelines, though. They are roadmaps that if a child has this particular diagnosis or this particular finding, we know from working all together what helps improve the outcome, what can help us have less cornea complications or less retina complication, and improve the actual prognosis. And it has made a difference in how not only do we here in the United States treat children with glaucoma, but the world as well. So that leaves other things. I mean, I think we're likely going to learn a lot I'm sure we are, from the families and the patients who talk to us today who have experienced childhood glaucoma, either in their child or themselves. I can tell you again, I've been doing this a long time, and I have watched the children that I've operated on at 3 days of age, actually one just recently, off at college and graduating. It's humbling. It tells me I've been doing it a long time. But besides that, it has been an education in itself that while we as physicians really want to do the best from the medical standpoint of decreasing the risk of visual impairment in these children, that there is so much more that when you look at this, that families face. And I would say that in the years of doing this, this is the area that we are now embarking on more concentrated than we have ever in the past. And that's moving out of the operating room, moving out of the clinic, and saying, how can we help people navigate this? One of the things that was an eye opener, so to speak, for those of us who take care of these children is looking at the paperwork that is required just to help children get what they're entitled to in schools if they are visually impaired. The other aspect is, again, medical knowledge is not universal. So teachers may say, oh, your child looks fine. He seems to read just fine. And they can't sit in a classroom that has glare. They all need sunglasses. Well, it takes a lot of educating other people about what is childhood glaucoma, what is pediatric glaucoma, what does this mean? Even if you've already fought the good fight and have kept the vision, there can be issues that come up later. And we're trying to create a system that will help these young families with so many things to juggle. It's quite the dilemma. So we know that there's this need there, and we see it from the minute that the diagnosis is made. I would say that at Bascom Palmer, at our center, the Balkan Center, we have most of the time, 99% of the time, our children are referred in with the diagnosis, and parents come for either a second opinion and or treatment or both. And we operate on infants and children with glaucoma every week. We see in a year more than 3,000 visits with children with glaucoma at the center. And, one of the things that I have learned, and we all should learn from our patients, is that, the parents have a lot of initial fears that need to be addressed. And so for any of the physicians who are in the audience today, I have to tell you, it helps to address those right off the bat. Are they doing the right thing? Are they in the right place? And everyone wants to know, what is the chance that my child could be blind? And it's one of those answers you don't really have readily, although we do have now better numbers that we can say with certainty from research that has been able to come together. But I would say over the course of my history as a professor in this field, that is somewhat new. But one of the nice things about creating a center for these children is not only that we are able to address these questions in a different manner, but the feeling of, I've never known anyone who has a child with glaucoma, and feeling so isolated. Because then when you're in these groups, and I strongly encourage parents to try to talk to other parents who have children with glaucoma, it is very reassuring to know you're not alone out there, and that pediatric glaucoma, while it can be an arduous and difficult road, it's not the end of the road. So I know this is a little off base from the perspective of diagnosis and treatment, but I just want to say that I think this is as an important a lesson for physicians and also for parents to understand. And that is, it is very, very important to have support structures for the long haul. It's not a sprint and a race. I can't tell you how many times we operate on a baby and the parents are thinking, that's it, right? Nope, it's not. We're going to have to go back to the operating room. A lot of times we'll have to go back, several times until the child is stable and or can be examined easily in the office. We've recently started a program called Patients, Parents, and Providers. Now, this organization is really just been going and growing quickly based on parents. So, patients, parents, and providers has been something where creating a network of support structures to help with all of the things that are facing the patients, the siblings as well, which has been something that's been really, really rewarding to deal with, as well as the parents, but the providers, the physicians. So we as a group just recently sent a survey to physicians who spend most of their time taking care of pediatric glaucoma because it's so highly stressful, to find out how are we doing as doctors, taking care of each other and helping each other. And having this organization is clearly the first step. So I think the next thing is physicians tend to want to say, okay, some of these problems, they're not mine. It's up to them to figure out how to get back to us and how to get childcare at home when they're bringing their babies in or whatnot. And I think that this is the dawn of really going back to the way medicine used to be, and that is really trying to be involved, but having a person, not necessarily a machine, but somebody who can help with organizing these things and help to coordinate it so that, oftentimes, we'll say, oh, gee, they missed another appointment. Well, it may not be the easiest thing to make so many appointments, and trying to find out or walk in someone else's shoes to see what do we need to do to make this difficult and long road a little easier. And ultimately, as the physician, I have to say that it really does take other people watching and being the guardian, so to speak. So these children are not making a choice on whether or not they get to the office. It's like it's different than an adult, clearly, because they're dependent on someone else. And that's why we need to, for many reasons, help the provider to keep that obligation. But it is never as easy. It's always, people can always say, oh, you're just putting in drops. Well, sometimes that can be very hard. Oh, it's just another visit. You must be used to it. That can be difficult as well. I can tell you in our center, we know people come from other states. They fly in, great expense. Organization is very tough. And we need to sometimes say, okay, can we get this closer to their home? And how can we do this so that the care is consistent? Because the other point is this: even though we treat the child in infancy, this is a lifelong monitoring situation. You really have been born with congenital glaucoma, but it doesn't mean it goes away. And in fact, there are certain set times that we know that intraocular pressure control becomes a difficult issue again. Puberty is one of them. In some of the syndromes, we know that there are certain times that we need to start checking. Children that have had congenital cataracts are far more likely to develop glaucoma associated with congenital cataract surgery. And if you follow these children for a lifetime, eventually, they will get glaucoma, whether it's in childhood, young adulthood, or adulthood. So from the beginning in the operating room, you see that this is the same baby, with the measurements and the initial visit in the OR to following surgery and the eyes being clear. And even with that, it's still a long road. And I say this with great optimism. I do, because now more than ever, I think we really have guidelines. In the past, I think physicians have felt like, they were on some rare road. And I think now that there are ways that we approach problems that have a little bit more research and dedicated answers and treatments that will help support the visual health of the baby, and hopefully the support for the family, that you have a team, and looking towards solid resources. Now, one thing I want to sort of end on is, in this era of the internet, everybody, Dr. Google, I encourage you to use the Glaucoma Research Foundation or other academic institutions that have information regarding childhood glaucoma, rather than just some unknown site. And I really do think that we've learned this recently in pandemic, there's a lot of bad information out there. Don't listen to it. Try to stay, on the reliable path. Trust your physician, and also remember that there should be some support structures that you can turn to find out if this isn't fitting with what other parents and physicians are doing for treatment of childhood glaucomas. Because there is an end to the road there where they get bigger. And as I said, I've watched them go from that 8 weeks. Actually, I think I've operated on them much younger than that, all the way through to adulthood. And I'm now taking care of their children. I have one with Axenfeld-Riegers, who just had her second baby. Her first baby has Axenfeld, but without glaucoma at this time. So, but it is a life, but it's certainly one that can have an outcome with maybe visual impairment. But fortunately, I think we have some real promise for the future in treatment of children with glaucoma. And I'm going to stay around, Michelle, if you'd like. I will certainly be here to answer questions, and I'm anxious to hear the families as well. So thank you very, very much. And thank you, Glaucoma Research Foundation, for being one of the sites that has good information on childhood glaucoma.
Thank you, Elena. That was enlightening. There was so much information, helpful information that you gave there for patients, for caregivers, for doctors. People will definitely be coming back to this webinar to learn more. As I mentioned before, now we're going to be joined by Hannah Eckstein and Jeff and Katie Brown. Before we get to everyone's questions, I was wondering or hoping that each of you could tell us a little bit about you, where you're from, what kind of glaucoma you have or your family has, and a little bit about what happened afterwards. Jeff and Katie, do you want to start?
Sure. Thank you for having us. Our son, Bennett, he was diagnosed at 2 months of age with congenital glaucoma. His true condition is Axenfeld-Rieger's, and it was a pediatrician who, on a second-month checkup, noticed some irregularity with his eyes. There was discussion of glare, and then there was an irregular shaped pupil, which then took us to an ophthalmologist who then diagnosed him with predominantly glaucoma. He is now 15 years old. He just finished his freshman year of high school. We can relate to all that was discussed earlier with the doctor. It's a long road, but we've learned a ton, and we've managed this over several years. We've had some pitfalls. We've had some successes. He has a glaucoma shunt in his one of his eyes right now that is helping with the drainage. But he is a happy, awesome, wonderful kid. The schools work with us. So we've learned a lot on our journey.
I am very glad to hear that you're working with Bennett's teachers. That's super important, like Dr. Grajewski was mentioning. I'm glad to hear it. Hannah, would you like to tell us a little bit about you?
Yeah, hi. So I was born with congenital glaucoma, and I lost the vision in my left eye when I was 11, potentially. Can't really remember. But yeah, I'm currently a senior in college applying to vet school right now. So my days are spent busy. I work in an emergency hospital here. I'm in Louisville for school, but I'm originally from Nashville. So yeah.
Thank you so much. So I'm going to go ahead and ask Dr. Grajewski some questions that actually came up about diagnosis, mainly from parents. Is there any genetic testing or prenatal screening that can take place if you know that it runs in your family, that any precautions that they should do before planning to have family, or when they're in the beginning, the first steps?
That is a very common question. And in fact, that's one of the reasons we have a genetics clinic and a genetics counselor in our center, because it's so common, and yet it's complex. So it's different for different things. So for example, the Axenfeld-Rieger's is a different genetics than is primary congenital glaucoma or juvenile open angle glaucoma. And the risks are different, and manifestations, like you can have Axenfeld's and not have glaucoma, or you can have glaucoma and not have the other manifestations, which can include cardiac problems and limb problems. But can you make the diagnosis in advance? If you have childhood glaucoma and you're planning your family, hopefully your doctors will have done some testing already. But if not, then you need to find not just any geneticist. It has to be really someone who is familiar with ocular genetics. And there are some very, very good ones that are out there. And they need to have a genetic counselor as well. I have had one mother who was having something called villus venous sampling before the baby was born. And it wasn't going to affect the outcome of what her pregnancy would be, but she decided to have the testing done at that time. And so the baby was born. We knew the child was going to have glaucoma 100%. And it was actually quite interesting because I operated within the first week of life, and that did make a difference. But yes, there is genetic testing that can be done. Absolutely.
Good to know. And if, for example, the child is born without glaucoma, and yes, they know that it runs in the family, at what stage should they start screening? I know they should probably be doing regular checkups, but will there be once a year that they should do screenings? What should be the steps for families that have, lots of people with glaucoma in it, especially the parents?
Well, it depends on what the type of glaucoma is. Once again, if it's something like juvenile open-angle glaucoma, that's every 6 months. Axenfeld-Rieger's as well, even if the child doesn't have glaucoma throughout adulthood even, needs to be seen every 6 months at the very longest interval, because these things can change over time. I mentioned congenital cataracts. So kids that have had congenital cataracts and surgery, they are particularly prone to develop glaucoma. And again, those are children that should be followed closely. 6 months, once a year is actually probably too long until you get into young adulthood. And then you're pretty sure that once a year is going to be okay. But otherwise, about every 6 months.
Great. Thank you. Jeff and Katie, what challenges have you faced as parents, and what helped you overcome those challenges? Doesn't have to be all of them, maybe a couple.
No, I would say in the beginning, resources and information. Mm-hmm. We really struggled with that in the beginning of trying to find information, read about it. And we had an awesome doctor that we worked with in the beginning who said very similarly too, you have to be careful of what you take a look at on the internet, because it's not always the kind of information that is truthful. And at times it can also be the most exaggerated information you see out there too. So to be cautious of that. And I would say that has gotten better over the last 5 years. There's more resources. You guys have some awesome information. There's some different Facebook sites, but that has been helpful over the last several years for us.
Well, and the only other thing I would add is the path is never linear. So there's a lot of ups and downs. So with Bennett, there were years that went by where he was in great condition. And then all of a sudden you were blown with, you were hit with a blow with, something else. So even when he was a child, and if there's a lot of other parents on here, at 7 weeks old, you're going, you're having these multiple exam under anesthesia with the potential of surgery. Never knowing that can be very stressful. So that's almost like a big time block. And then when Bennett was 5, he took a blow to the eye. So he actually had to have surgery. So there was, there were all these moments. And then until very recently, he's been, surgery free. So I would say that one of the challenges is that as an expectation as a parent, know that there will always be these ebbs and flows. And to do your research and to find what you feel is the best care. Right now, his primary ophthalmologist is out of Chicago. We live outside of Detroit. And so we go to Chicago 4 times a year. So, which is not always something that everybody can do either. So you got to kind of recognize that. And, to draft off what the doctor was saying earlier, which could be a really important resource, is to try to find those local doctors that are experts and utilizing the experts like at Baxham or Wills or Northwestern or some of the other leading glaucoma university and training, or Duke. We went to many of them, to try to find different resources locally too.
Yeah, finding the right doctor for you is super important. So I'm glad you did your research, finding out who was the best fit for you and your family. So good on you. We always root for patient advocacy or parents. So that's good that you did that. And we encourage it for everyone else too, to make sure you find the right doctor that you feel comfortable with, that you can talk to, and, talk out the different treatments and what the next step is and the journey that you're going to be having ahead of you. Everything that Dr. Rajewski was mentioning, it's super important. Not many people might have that with their doctors, and having that support system from your doctor too is critical, I think, especially when it's such a scary time for you. And now moving on to Hannah, would you like to tell us a little bit? I know you were saying when you were younger, you didn't remember, but maybe now as a young adult, what challenges have you faced, and what's helped you overcome those challenges?
Yeah, so one of the main challenges is I want to be a doctor. So the issue is that I'm blind in one eye, so my depth perception can be a little iffy. And which I'm fine driving. My friends like to make fun of me. They don't let me drive at night anymore. It's not the best thing ever to let me drive at night. But so one of the main issues I had was just like, especially now that I'm applying to veterinary school, it's kind of coming back. So I'm like, oh, it's really happening. It's just been, I know that there's so many detailed things that like suturing, surgery, things like that have terrified me. I've been lucky to have really great veterinary mentors who, one of them let me practice on fake skin and things like that. And I have a little kid at home just to make myself feel better. It's just more being afraid that I'm not going to be able to do what I want to do because I have issues with my left eye. But when I was a kid, it was more like I couldn't play sports because I got hit in the eye too, like the Browns family kids did. And so after that, it was no more sports. It was over after that because it was like, oh, nope, no risking the eye. So just kind of being afraid and kind of being different because like I never knew anyone else with glaucoma or like, especially my age. So it's just like, I have this strange thing, like, especially when I lost my sight in my left eye because like no one told me because I was 11 going into surgery that I was going to lose my vision. And so I don't think they knew either. But it was coming out of that and having to adjust, especially as a little kid, which I guess hopefully made it easier because I didn't pay too much attention. But yeah, it's mostly fear. Like it's gonna be a lot, but like sometimes I'll like look at the world and I'll look at it and be like, this could be some weird accident can happen. This could be the last time I could see like my friends' faces or like my pets, or like the world around me because I only have one eye left. So it's very possible. And I've been lucky that my glaucoma is managed. But how I got through all that was definitely, my mom said I was lucky to be born a stubborn child. So I am very stubborn. And as I like to say, I live on spite. So I've been told several times that I should not become a doctor. So now I am thriving to show them that they're wrong. And so I think just finding out what drove me, like I've had a goal since I was 15. I've worked in a veterinary hospital since I was 15, and I knew since then I was going to make it work. And I think that helped me a lot.
Your determination is amazing. And I think that's really something to admire and encourage for other patients too. Just to have that determination, you'll get what you want done. And probably when you were younger, we didn't have social media and all those things. You were saying when you were younger, you didn't know other kids that had glaucoma. Do you use social media or any other form to talk to other kids that are in the same situation?
No, but actually I do get reached out to by parents a lot on Instagram, especially when you guys post something about me. They reach out and they're like, my kid's having issues. And like, I don't like, cause like, I know it's hard for parents cause like if you especially didn't have it, it was genetic in my family, but it hadn't been around it happened previous generations, but not with my parents. And so I think just like helping the parents makes me feel a lot better because I know some kids out there are getting some help that I didn't have. Like I think a lot of it was to do with how independent I was as a kid. I don't know if glaucoma played any part in that, but I know a lot of kids aren't as lucky, and I got lucky to go to some amazing doctors. Like we traveled to North Carolina, I think twice a year when I was a kid. So I think it would be helpful to a lot of kids to know they're not alone and especially have their parents support them. And I'm happy to help them out and do that. But I don't think I've ever met anyone my age with glaucoma, actually, still to this day.
Wow. Well, thank you for offering. That's great to know for anyone out there. It's good to be able to communicate with others in your same situation, in any situation, not just talking about glaucoma. I do have a question about SLT. Is SLT performed in pediatric patients? Is that a line of first choice for pediatric patients?
No,
Okay.
it is.
Okay.
Mostly because it depends on the type. A lot of the pediatric or childhood glaucomas, the angle itself where the SLT would be done does not appear normal. In juvenile open angle glaucoma, however, it is something that is an option that can be tried, but it really depends. That's that one specific type of glaucoma, but otherwise, no, it really is not known to work. There are other kinds of lasers that can be used on eyes with childhood glaucoma, and those are sort of reserved for later on, but they're not the SLT laser.
Okay, good to know. And we have gotten some questions about research. Can you share a little bit about childhood or juvenile, pediatric glaucoma? What kind of research is out there? Is there maybe stem cell therapy or gene therapy? Anything you can share?
Sure. There's quite a bit now that we have a research network that has really changed the way we do things. So one of the things that we have learned is that treating the angle even more than once can be effective, and that the longer you can wait before you put in a glaucoma shunt, the more likely the shunt is to be successful. So some of the newer surgeries, like we hear about in adults, MIGS surgery and that sort of thing, it's odd because those surgeries are in the exact same area we operate on for pediatric glaucoma, the angle, the drain. And so the concept of operating on the same area again is new and comes from the most recent research. Also, it allows us to buy time until a shunt is needed. I mentioned that we know pressure can go up again, like in puberty or certain times, or if something else happens, trauma we've heard about today. As long as you can delay till you need to have the artificial shunt, usually the better the success rate for that shunt.
Great, thank you. And we're running out of time, so I'm just going to have one last general question for all of you. Any advice that you'd like to give to patients, to parents, fellow glaucoma patients as well? Anything you would wish you'd known that you know right now that you'd like to let others know?
I mean, I guess I would say we're managing this. Our son is managing this, and it felt really scary in the beginning for those first couple of years, and those surgeries were scary. But we're managing with the help of great doctors, with great medications, and our fingers are crossed that something comes down the road that helps even more. But I think.
Well, and the only other thing I would is to advocate for for yourself or for your child, and don't ever be afraid to to reach out to make sure that you're getting the best care in your local area. So and finding that specialist, because it is a very specialized disease. And then know that there's hope. I mean, Bennett played high school football. He is on the track team. He has a lot of friends. He's got a great sense of humor. So there's hope. So there's.
Yeah.
Thank you. That's a great message.
So my message would be, don't treat your kids that differently because they have glaucoma, because I know I especially hated when things had to be specially arranged for me. because I don't know, I don't like attention that much. And so, and things had to be specially arranged, it made it worse for me, because I was like, why do I have to be different? Like, sure, like if your kid needs help, if they need additional resources for test taking and things like that, that's fine. But like when I was younger, I remember my parents being overprotective, and when they're figuring things out, and they're like, let's let everyone on the team or everyone on everything know about our daughter. And like, if that's for their safety, that's fine. But like, it was just because they were like, oh my God, our child. And like, it just made everything uncomfortable. And I would also say, like, treat your kid like an adult, like it's their illness if they're the one that has it. Like, I didn't know anything about glaucoma until college. Well, like I knew like in general what was the reason, like what was going on. But I actually wrote a genetics paper on it, like a term paper on it, because I was like, I asked my professor for special permission, because I was like, I would really love to learn more. And part of me was kind of like, why wasn't I ever taught? Like, I feel like at all the doctor's visits, it was doctor talking to parent, doctor talking to anyone but me. And I barely knew what was going on. Which on the other side of that, I would definitely say protect some things from your kid. Because when I was like 12, I have like a very distinct memory of a doctor telling me that there is research for glaucoma, but my special case, because of what happened to my left eye, there is no possible way there'd be a cure in my lifetime. And as like a 12-year-old kid, that's really hard to hear, because like kids are full of hope, and part of me still hopes that maybe my special case will be different and maybe someone will come out with something. But like, let your kid have hope, but also keep them educated, because it's their decision on what they want to learn about themselves and what they don't, instead of just hiding everything or just talking over them. So I would really appreciate being more educated as well.
That is very insightful. Thank you, Hannah.
I would like to add that there is not much you can say other than what these families have said. It's been wonderful to listen to, but I do want to reinforce what was said about the physicians, that they are those physicians that are comfortable taking care of infants in particular. But infants and young children with glaucoma, it's few and far between. And it will not hurt any physician's feelings to go somewhere that is a academic institution that specializes in this, and have not just another opinion, but to create a partnership between that doctor and a local doctor so that you can work as a team. And I'm a great believer in teams for support, for care. And also, I think that it is better for the physician as well. I mean, you don't want to put a doctor in a position to care for a situation that to them is so uncommon that they don't feel secure taking care of your child. So, not everybody has the luxury to travel, but now I would say I do quite a few consultations via the internet with physicians and with the child. So this team kind of work can happen. So do not hesitate. If you seek out another opinion, your doctor will not mind. They may actually go, "Whoo, good. I want to hear what someone else who does this all the time says." So please do that. And again, thanks to the Glaucoma Research Foundation for all you do to organize us. Thank you.
Thank you. All the information you provided today during your presentation and now during the Q&A, your points of view, your advice, thank all of you. It's really been amazing and very, very helpful. And if we weren't able to answer any of your questions today, remember our website and our social media platforms. They have plenty of information for you. We try to stay up on top of everything and provide it on our website about glaucoma and about research out there. Once again, thank you to Aerie Pharmaceuticals for your sponsorship. And thank you everyone for your attention today, as well as your interest in Glaucoma Research Foundation. Because of you, the cure is truly in sight. See you next time.